Hi, Sherry, please. Nice to meet you. Nice to meet you. I'm trusting you. I'm rotating here. Excellent. Okay, so you're right. You're right. Me? Sure. And I will connect you with Ray through my correspondence. Hey, how are you? What the steps are here? Okay. What are you doing? Okay, great.
Yeah, pretty much.
You're also often hired. So come by.
Dinner that Kathy's doing.
Columbia. Right there.
Yeah, thank you.
Great.
Leo, we're using the telephone. Can you hear us now? I don't know.
Leo, are you there? Leo?
Okay, all right. Okay, so we're going to get started. I would like to welcome you to our first combined Division of Behavioral Health Services and Policy Research and OPAL Center seminar. Second? I'm already getting it wrong. Okay. All right. Well, so I'd like to welcome you to our second. It's great to see a nice crowd here. We have the pleasure of hearing from, I don't know, someone who's like been a giant in the field. No, seriously. I mean, not like really tall. Right? Sure not. But someone, I mean, you know, who I think I've admired really since I started at University of Maryland in the Health Services Research Group. So Dr. Vliet is the Dean of New York University's Robert F. Wagner Graduate School of Public Service. Prior to that, she was Professor of Health Policy and Management at Columbia University Mellon School of Public Health, and she was Chair of the Department of Health Policy and Management from '98 to 2009. And I think Dr. Vliet had an adventure, I think, in Washington.
I did. That's a good way to put it.
Where she served as the Assistant Secretary for Planning and Evaluation at the Department of Health and Human Services. And we are so glad that you had the courage and sort of fortitude to do that from July 2010 to August 2012. Some of you may have heard of a book that she co-authored with Richard Frank, which I've been hearing about for really since as long as I've been paying attention, Better But Not Well, Mental Health Policy in the U.S. since 1950, a really important book. So we're really glad to have you here. We will interrupt you, we promise.
Okay, so please interrupt me a lot. I think one thing we didn't say is that I have a PhD in economics, and that in economics, the tradition is to interrupt the speaker from the get-go. So I've already spoken longer than I would have been able to if I were in an econ seminar. So what I want to do, I'm a dean now, so I don't have as much time to do new research projects as I would like. And so I'm actually going to throw out a bunch of ideas that I've been thinking about and working on, and some of them are old and you have already seen them, some of them are new. So just here we go. So what questions can I make this slide work? How do I go forward? Which one? The arrows? The arrows are not working. Right. Oh, here the arrows. The arrows. Oh, up and down? No?
Space.
Okay, so just hit the thing? Tap this? You can use the arrow. Okay, now I can use the arrows. Okay, so I'm going to talk about inclusion and exceptionalism exceptionalism and mainstream and something about health reform and basically focus on this paradox, which I think is really the one that is most motivating or interesting to me, which is that we actually have gotten better at treating people. We are treating more people. People's living conditions have improved, and we are still not seeing progress on a lot of the fronts around inclusion. So what is going on? That's sort of the puzzle in the back of my head. So
So what do you mean by inclusion?
okay, so I'll show you a couple of things in a second, right? This is the number of people who are collecting supplemental security income or Social Security disability income because of a mental health disorder. The early numbers in SSI are kind of kludgy from like 2002 to 2005, but you see that these numbers are going up. They're going up pretty consistently, especially for SSDI. They level off a little bit after 2013, but that's a big issue in SSDI. That the trust fund that funds the disability insurance program is running out of money, so there will be policy attacks on this program, and there were a lot of people with mental health problems for whom their mental health problems are the reason that they are on disability insurance. These are not intellectually disabled people. I've only included people who are under 65 and have mental illness. So that's who this is. So that's one measure of inclusion, of being part of the community. Here's another one that I bet you haven't seen. This is whether people voted in the last election. I don't have the latest, so I can't tell you what happened in 2018. But people who had more than 2 days of mental illness, reported more than 2 days of mental health problems in the prior month, more than 7 days, are just less likely to have voted. That doesn't really matter. I'm going to show you some more things later, but there's lots of measures of being a part of a community that people with conditions related to mental health are not doing well. So now I'm going to switch gears for a second and talk about some of how we might think about this in a couple different ways. And I think the simplest one is actually starting with something that Richard and I talked about in Better But Not Well, and that I think is really a big focus in thinking about mental health policy all along, which is the distinction between what I would call exceptionalism and what I would call mainstream policy. What do I mean by this? A lot of what we think about in the policy sphere around mental health are policies that are about mental health. So parity is about mental health. Stand for block grants are about mental health. These are policies that are designed around mental health conditions, and there's a pretty broad range of them. By mainstream, I mean policies that were designed and intended without any focus on mental health at all. So Medicaid just exists. Food stamps exist. These are mainstream policies. And we can think about the world as also having, we'll talk about later, exceptionalist and mainstream dimensions to it that I want to talk about. And what we learned in Doing Better But Not Well was that mainstream policy has had very large impacts on the well-being and health of people with mental illness. What I'm going to show you later on in this talk is that mainstream changes continue to be probably the singular force that affects people with mental health, even though we tend to be thinking about it from an exceptionalist lens. And that actually may lead us to think about things in a different way. So I think now you can all, I'm going to show the slide that I should never show here, but you can all criticize me because you know this better than me. One question that you really have to think about before we do this, and I'm taking a very strong position here, which I think may not be merited, but maybe, is that the basic underlying epidemiology of these illnesses isn't changing over time. Now, that's a little bit in conflict with things like the enormous increase in anxiety disorders that we see on college campuses right now, or changes in for what we thought changes in the prevalence of depression. So some of this, you have to think about this, and I'm not a person who can think about this because I'm an economist and not an epidemiologist. But I do think you have to think about whether what you're seeing is differential manifestations of the same underlying problem that are just showing up in different forms. And so now this thing is called anxiety disorder, or it manifests as an anxiety disorder that was something else before. I don't know. But a lot of what I'm going to say is predicated on the idea that people are not any crazier, to use an inappropriate word, today than they were in the 1940s or 50s or 60s. But there's biological basis to these conditions, and and that biological basis is pretty steady. And certainly, I think if you talk about the most severe conditions, that's less in dispute than if I talk about less serious conditions. So before I go on, does that assertion actually ring okay with you? Because if the problem is that actually there are just more and more people who are suffering from these problems, not that we're not treating them, it's not something else, it's actually that the actual disorders are increasing in society for some reason, that's something that we need to deal with, but I don't think it's okay.
I don't completely buy what you said. So I'll break the ice here. I mean,
Yeah.
So you said that these are biologically based conditions.
Or something, or it could be an interaction between biology and environment, whatever, but there isn't anything huge going on in prevalence.
Well, I mean, I guess if you then, I'm not an epidemiologist, but it seems to me that if you have, for example, a disorder that is influenced by trauma,
Right?
then, I mean, I would want to study this. My sense is that there may be more, at least there's more awareness of trauma.
There's certainly more awareness of trauma. I think it would be hard to argue that there's actually more trauma. I mean, crime rates are way down. There's nice evidence on the risk of violence, which seems to be declining.
We've been at war for 20 years now.
We have been at war for 20 years, but it hasn't been a war that has affected a large segment of America, the existing American population. And there were a lot more people in Vietnam, for example. We've had, I think it would be hard pressed to argue that the rates of trauma, besides the rates of diagnosed trauma are certainly up. The rates of trauma per se, we've had a lot of horrible things happen.
So in the ADHD literature, there's a huge debate about.
Right.
So I don't know that.
So, but that is the premise that I'm working on, so let me just stop there and say, we try, and part of this is the epidemiology is crummy on this, pardon me. Because people use different instruments from time to time, and they don't, if you look at the NCS and the NCS replication, it's not much change, but that's not a big period of time. We looked at Midtown Manhattan, which was back in the 1950s, but the instruments are completely different. So,
Well, I mean, what do they say? The easiest way to change the prevalence of a disease is to change the definition of it.
we do that a lot.
Right.
And we have new treatments, and then so we have these new diagnoses that show up because they're treatments. All right, but just by this, because otherwise the rest of what I'm going to say isn't going to make any sense at all. So here we go. So more people are getting treatment, and I didn't actually update this much, but if I went further forward, I'll show you some more slides. More people are getting treatment. There's still horrible undertreatment. There are still a lot of people who should be getting treatment who are not getting treatment, but on any measure, we're doing better than we ever have before. More people are getting treatment, even though most people are not.
Enter your access code or
We are mostly looking at mental health, but I'm pretty sure that if you look at substance abuse disorders, we'd see that too. I mean, we never did a very good job. We're not doing a worse job. We've improved insurance coverage. We've actually added treatment facilities. Probably have more people getting treatment.
enter your attendee ID number
But-
followed by pound. If you do not know your attendee number,
We should do it.
pound to continue.
See, even some serious mental illness. And this is mental health conditions. This actually is this is your point. For substance abuse, you don't see very much, but for mental health, you actually do. This is just in the recent past. A lot of that is improved diagnosis and treatment in primary care, so a lot of the increase in utilization. And people are spending less money out of pocket, which is good, so there's better treatment access, all good. There is evidence that the quality of care people are receiving has improved. So careful studies that look over time at whether people are getting guideline-appropriate care suggest that more people are getting guideline-appropriate care. More people are receiving appropriate medications and fewer people are receiving inappropriate medications. More people are receiving higher dosages of treatments. So again, there's a lot of really lousy quality care out there, but it's but the trend line is going in one direction. Because I'm trying to make the argument that many trend lines are going in one direction and the other one isn't. So, right? And more people are living independently or with their families than used to be the case, because we actually provide people with income supports, which we didn't used to do, really until the 1970s. If you had a serious mental illness and you were not institutionalized and you were not able to work, there wasn't really any way for you to feed yourself. Or if you had a child who had a serious mental illness, an adult child, say, with a serious mental illness, you had no way to compensate for the loss of income that you might have from taking care of that child. Now we have programs that provide that income assistance. I think it's particularly important in that latter case. So what we probably haven't seen actually is a lot of improvements in the quality of the individual pills themselves. But if we did see that, it would only make my case stronger. So we need more improvements there. More people. More financing through private insurance and Medicaid, increased access, this is really to social services. These are kind of amazing numbers, right? Very large numbers of people with serious mental illness who are receiving some sort of income support or some sort of food stamps or substance housing assistance. A big change from the past. So why do I emphasize this? These are mainstream programs. These are not programs designed for people with mental illness. These are not inpatient mental health treatment facilities. These are not programs in many cases where people even thought about mental illness when they were putting the program in place. They have had the beneficial effect of improving the well-being of this population. So just to recap here, mainstream policy changes have improved access to care, quality of care, and out-of-pocket costs and living conditions. So we focus a lot on things that are specific to this population. We want to think a little bit about the broader stream. Okay, so I'm now going to switch gears and talk for a minute about the Affordable Care Act, because I always have to talk about the Affordable Care Act, and what it does for mental health, because it also shows you sort of the dimensions on which these things matter. So where are the exceptionalist pieces of the Affordable Care Act? The essential health benefits include mental health and substance use. So what does that mean? If you know, we just went through 2 years of repeal and replace. Do you remember all that? A nightmare, a 2-year nightmare. It shouldn't be political, but now the 2-year nightmare is over. One of the questions that has been, one of the issues that has been a piece of much of that conversation is whether insurance companies should be allowed to choose what benefits they offer. And have you followed that conversation about whether insurance, okay, so that actually turns out to be incredibly important mental health issues, because when we looked at what insurance companies did not offer back in the day that they did not have to offer everything, can anyone tell me what benefit was the most common that they did not offer? This is a trick question.
Psychoanalysis.
Pregnancy, maternity services. Okay, they did not offer maternity. Number 2 was substance use. About a third of private non-group insurance contracts didn't cover substance use. About 20% did not cover mental health. So, now why not? Because following up on the conversation we were having earlier, because people do not demand it. If we don't, right, so nobody can sell a policy that doesn't include cancer. But they do sell, people who don't have a mental health condition say, I'm not going to get one, I don't need this policy. They're wrong, but that's the way it shows up. All right, so the first exceptionalist piece of this is that we include mental health and substance use. The second piece is that parity, which had happened a couple of years earlier, the quintessential exceptionalist policy, let's make sure we pass legislation to make sure we treat mental health just like everything else, is extended to all the populations. But, and there's, like, reinsurance, coordinated care, home and community-based services. The Affordable Care Act is mostly a mainstream piece of legislation, so mental health really doesn't show up most places at all, just in those few exceptionalist places. But there are lots of places in this mainstream law that affect people's well-being, mental health well-being, insurance reform. Oh, where am I? No, I'm going the wrong way. Insurance reforms, coverage expansion, delivery system reforms. Okay, so pre-existing conditions, that's just won the Democrats the election this time. Where does mental health show up in pre-existing conditions? What would you think? So, I don't know. This is from Aetna, taken off their website in in 2010. This is anxiety and depression, including anxiety, depression, obsessive compulsive disorder, PMS, I like that. If you are over age 18, stable on a single prescription medication, you've never had a suicide attempt, and you've never been hospitalized, and you are 23 to 29, a reasonable thing is to increase your premium by 50%. Okay? If you are as above but stable on 2 prescriptions, the minimum is to increase your premium by 20% and up to 60%. Your premium, right? So that's like $200, $300 a month. If you're age 12 to 18, you're stable on a single prescription medication, you've never had a suicide attempt, and you've never been hospitalized, that to me means that is a reason for a coverage denial. This is taken off the Aetna website. It's not like me being obnoxious.
When was this? When did you?
Before the Affordable Care Act went, went into place. So probably 2010, 12, I probably took it off. You couldn't find it now because we don't let people do this anymore. But when people talk about eliminating protections for pre-existing conditions, this is what it means.
So it's like 60% to D, and D is denial.
Yeah. Okay, so here's another study. This is a study that, because nobody believes this, this was a study that was done in 2001. What they did is they sent out case descriptions of selected people randomly to insurance companies and asked them to give them a quote. So hundreds of insurance companies, hundreds of cases. And one of the cases, E, is Emily, a 56-year-old widow who is situationally depressed. 23% of the insurers rejected her case altogether. That was what was wrong with her. She was situationally depressed. Of the 46 offers she received, 23 excluded coverage for depression. 30 offered a premium surcharge. The average annual premium was $4,000. Some people charged you $10,000. This is in 2001. So even something so you think about mainstream policy, we worry about people with mental health conditions. You probably weren't thinking about pre-existing condition exclusions in your population. But yes, these populations are very much affected by even such simple things. Okay, Medicaid. Wait, did I go the wrong way? Oh, coverage expansions. Okay, so coverage expansions for people under 32%, and health insurance exchanges and tax subsidies and all of that good stuff. Also, so Medicaid before the ACA. Before the ACA, states could expand Medicaid if they wanted to, and we're in New York, so everything is lovely here, and we did it, and we expanded Medicaid. You could see us with our brown and yellow line. The brown line is really important because those are single adults. So if you're a single adult with an income under 100% of the federal poverty level, New York expanded coverage in about 2001. We did pretty well. But you notice that there are very few brown bars on this chart, which means that in most states in the United States, before the expansions in the Affordable Care Act, if you were a single adult, no matter how little money you had, you were not eligible for Medicaid. That means you were not eligible for anything. So we're kind of used to New York where there used to be general assistance Medicaid and all that things. But in most states, there was no Medicaid. And even for parents, so these are people with dependent children, Medicaid income eligibility is well below 100% of the federal poverty. So, post-ACA, this is what happens in expansion and non-expansion states. So, lots more people are getting services, they're getting insurance. So you can't read the legend, I'm sorry. That is the number of days with mental health problems that you had in the past month. In the Behavioral Risk Factor Surveillance Survey, this is the best measure of mental health we have. So the blue bars are people who had no mental health problems. The purple sections are people who spent 14 or more days in the past month reporting that they had poor mental health. Okay, so they were really not doing so great. So overall, 2.7 million people in those populations with 14 plus days of mental health problems gained coverage in the first 2 years after implementation of the Affordable Care Act. Most of that gain is in the expansion states. Look at in the right-hand corner, how big the decline is in the purple bars. So who are these people? These are people with pretty serious mental health problems who don't qualify for SSI or never tried to qualify for SSI. And so just giving them insurance coverage has expanded their well-being a lot. And so this is maybe not so good if I'm talking at PI, but there's this great, amazing study in Oregon called the Oregon Medicaid Experiment. Have you heard about this? How many people here have heard about it? So many people have not, so let me tell the story because it's such an amazing story. One of my fellow economists, a woman named Amy Finkelstein, was driving her kids to daycare or nursery school in Boston when she was listening to NPR. And she heard that Oregon, the state of Oregon, had wanted to expand Medicaid, but they ran out of money. Now, most states, when they run out of money to expand Medicaid, they use a waiting list, and they just let people sign up, and they do first come, first served. But Oregon, because they had Governor Kitzhaber, they were kind of nutty, they decided to have a lottery. And so you put your name in, and if you won the lottery, you got Medicaid, if you qualified. Okay? So you had to qualify for Medicaid to enter the lottery, and if you won the lottery, you got Medicaid. So Amy said, oh my goodness, this is a randomized experiment of Medicaid. You could never get a randomized experiment of Medicaid through an IRB, but they just did one. And so she was able to get all the data from Oregon and follow up and do surveys. She got a lot of funding and try to find out what happens to people when you gave them health insurance. So the first thing that happens when you give people health insurance is they become happier. And it's not because they get treatment. Their depression levels go down. It happens before they even get into treatment, which makes tremendous sense if you've ever thought about what it would be like to not have health insurance. It also turns out that they are more likely to register to vote. That came out last week. So if you go back to my social inclusion slide right at the beginning, getting people to be having their mental health treated better improves their depression, increases voting. There's an increase in visits, there's an increase in prescriptions, but 2 additional days of good mental health a month, most of the effect happening right away. So, and some of the follow-up studies on the affordable care act. So, coming back to my paradox. The mainstream reforms have worked, treatment access improved, treatments improved, living conditions have improved. What's going on in social inclusion? So, is this problem exceptionalist or is it mainstream? Is what we're seeing here specific to mental health, or is it actually something that's happening in the economy widely? And I'm actually going to be totally contradictory in my answers because I haven't come up with an answer yet. So I'm going to show you pieces of evidence that kind of work in both ways, and you can tell me what you think. So the first thing is this one, which is I showed you this happy story about how more people are living at home and they're living with their families and people can keep their adult children at home and all of that is great. But if you look at the data on what share of people with a mental illness are homeless or incarcerated, that bar has also gone up. Okay, we actually calculate this in the book by reverse engineering using Bayes' rule. So what we do is nobody actually does a study of where people with mental illness are. What we know is what fraction of homeless people have a mental illness. And we know what fraction of people are homeless, so we can reverse engineer what fraction of people with mental illness are homeless. Does that make sense?
As far as you know, has that trend continued?
We have not updated it, and we should. But I will show you why I'm almost certain it has continued. And here's why. The question is, where is this coming from? And the answer is, it's coming from the mainstream. What happens is that people with mental health problems are far more likely to be incarcerated than is anyone else. And we started incarcerating a lot of people. And as we incarcerate lots and lots of people, the people that we incarcerate are people with mental health problems. So there's no evidence that people with mental health problems, so there are several studies trying to figure out whether deinstitutionalization, for example, has led to increased incarceration of people with mental illness. And the best of those studies, as I read them, say the answer is no. Instead, what's happened is we have been incarcerating a lot more people, and so we've been incarcerating a lot more people with mental health problems. Very hard thing to measure, but if you look at this picture and you think about the picture that I showed you before and the timing, 1970 and 2000, you can see here that this is an increase that's happened in the incarceration rate. We see more people with mental illness incarcerated because we see a lot more people incarcerated. And most of those people obviously don't have mental illness. What about employment? So this is how many, days of employment you had in the past, month by mental health status. It's the same thing, it's a BRIPA, so it's 14 days of mental illness compared to 0 days of mental illness. And what you see here is people with 14 days of mental illness are much less likely to be employed, and they are much more likely to be in some other category. And we did this run in the NCF. This is not, we just did it. This is how many people report an other status. They're not working, they're not a student, they're not a home worker, and they're not retired by particular diagnosis. And what's amazing here is that every single one of them is above the line. Doesn't almost matter what's wrong with you. Any one of these conditions is associated with not being in any of those standard categories. So that I haven't showed you trend, but I did show you the trend in the beginning. This is rising work disability. So this is from general disability data. The gap in working between people with and without a disability, which has been going up. And the second one is disability benefit recipients. So that's been going up, similar to what I showed you in mental health. So I'm trying to decide whether this is exceptionalist or mainstream. Is it that we're just seeing more people being locked out of the labor market for one reason or another, and that's because of disability, or is it because of mental illness? So the blue bars here are the share of people on SSI who have a mental health problem, and the red bars are the share of people on SSI who have something else. And what you see here, I think, is nothing. So it's a disability problem more than it is a mental health problem, it looks like, or a working problem.
Unless people have comorbid, unless there's, we know that there's a huge amount of comorbidity.
There's a huge amount of comorbidity, but there's no reason, you'd have to make an argument that comorbidity has been rising, and I'm not sure that that's the case. There's, it kind of fluctuates a little bit, but it isn't a very big change over time. It's more about a mismatch between people with disability and the labor market. So, I think mainstream policies have been the most important factor in improving well-being, but I also think mainstream forces have probably been the main factor in causing people to do worse. So the things that are happening in that way. So, how could we think about this? I don't know. We need a model, right? You were saying you don't like models, and I'm going to try and come up with a couple here. But anyway, so one is, you have a condition, and we move you to a treated condition by making treatment more accessible or higher quality or whatever. And then the treatment condition moves you to functioning. Social and economic supports help you get there. Social and economic conditions either help or hurt you from getting there. So this is, you can see I'm not a designer, so I don't make very beautiful models. But this is a kind of a way of thinking about this. So I'm going to show you, trying to puzzle this through, Richard Frank and I just got a grant last week from the Robert Wood Johnson Foundation to try and study the next thing I'm about to show you more carefully. So I would really appreciate any thoughts you have on how to think about this problem. So here's wasn't that cool? So we're doing better on quality and accessibility, we're doing better on social and economic support, but we're doing worse and worse on social and economic needs. That's my take on it. Okay, so here's I started working on this when the Olympics were on, and I was really struck by the Special Olympics and the Paralympics, the ones for the disabled people. And I was thinking about how, for physical disabilities, technology has really changed that last mapping between treatment and functioning. We've actually intervened, and we now have not all conditions, because actually I thought what I was going to see is that people with disabilities are more likely to be in the workforce because we have all this accommodation, and I don't see that. But I think you would imagine that people with movement disabilities are better able to engage in the workforce, or people with sensory disabilities are better able to engage in the workforce because of technology. This is my conjecture. I don't know that. I took those, aren't those cool? Those are from Google, from the Paralympics. I thought I was gonna see something that looks better in terms of people with disabilities and having work limitations. I actually don't see it, but it's a thought. So what's the mainstream forces here? Okay, so what is a mental illness? We never even defined it in our paper, which is in the book, which is funny. It wasn't until we started working on this that I tried to figure out what the definition. So this is NAMI's definition. A mental illness is a condition that affects a person's thinking, feeling, or mood. Such conditions may affect someone's ability to relate to others and function daily. Is that okay? So this is the top 10 skills that the World Economic Forum says people are going to need going into the 21st century. Complex problem solving, critical thinking, creativity, people management, coordinating with others, emotional intelligence, judgment and decision making, service orientation, negotiation, and cognitive flexibility. When I look at those two things next to each other, I see a problem. And we can see that problem building over time. This is the share of employment in the United States by industry. So agriculture, mining, construction, manufacturing. If you think about a person with a mental illness who might be able to function in a job, you probably are thinking about a job that is in one of those kinds of sectors, right? A job where they don't have to interact a lot with people, and it is a fairly routine set of functioning. This is conventionally how we might think about this. Now, when you look at what's changing, right, we have increasing numbers of people in jobs that mostly involve interacting with people, changing what you do to respond to the person that you're seeing. I think this is actually quite challenging. So this is another World Economic Forum thing. Routine cognitive tasks are declining as a share of the labor market. Non-routine manual tasks are declining as a share of the labor market. Routine manual tasks are declining, and what's going up the most is non-routine interpersonal tasks and non-routine analytic tasks. I think this actually these are mainstream forces that cause exceptional problems for people that we are concerned about. So implications, what are we going to do? We need to hang on to insurance coverage. We need to make sure people are okay. But we also need to do more things. We probably have to give people more support. We have to give people more supported housing and more supported employment because they're living in circumstances that are going to be, by their nature, more challenging. And when we think about work, I think, so this is another, see, I did two here. I never do these, so I'll tell you. Another way to think about this in the context of disability broadly is the relationship between work and health. So is it the conditions of work that are causing people to have problems, stress, hours, and so on, sick leave, and things like that? And do we need to be thinking about policies around minimum wages and paid sick leave for people with mental health problems? How would that affect the ability of people to function? And actually, I've never seen any research on that. So New York City just imposed paid sick leave, for example. Does that allow people with depression to stay at their jobs longer? Because when they're not able to come to work, they can stay home and keep their jobs. I don't know. And then you could also think about the reverse. Are we seeing disability support incentives to enter and leave the labor market that are moving from health to work? Can we do more around accommodation and disability? So I know that you are doing cognitive remediation. So, and I mentioned this morning, so I think some of this says we need to be doing additional tools to help people to be coping with the changes in the labor market that are coming forward. And the final bit of this is, I think, the canary in the coal mine aspect of this, which is we have seen a big decline in labor force participation in the U.S., not only among people with disabilities, but in general. And it looks like it's sort of the people with work limitations are sort of leading the charge here. They're the canary in the coal mine. The workforce demands are changing, and this is the group that is affected first, but also prestigious changes in the future. So with that, I will stop since people did not interrupt enough. So what we are doing, Richard and I, actually is using a couple of large longitudinal databases that have information about mental health, like the National Longitudinal Survey of Youth, and mapping them to occupational categories and trying to see how the fit between mental health conditions and the nature of work in the way that I just showed you is changing over time. And 2 or 3 years from now, I may know the answer.
Well, I'll ask a question, because in some countries they give incentives to businesses to hire people with disabilities.
So one of the dimensions that I think that we could think about from a policy perspective here is that the Americans with Disabilities Act requires employers to provide accommodations to people with disabilities. Its application to people with mental health conditions is more limited because of the way courts have figured this out. But I do think, if you think about the policy issues that you might think about working on, one is, what would an accommodation be?
Right, well, so there's that side of it, but some places actually give tax advantages to companies that will hire certain kind of people with disabilities.
Yeah, so we do this for intellectual disabilities. We do this for intellectual disabilities to some extent.
But we don't do it for other disabilities. We don't do it for physical.
No.
And I guess what I'm curious about is in countries where they offer those incentives, and where there is also a real change in the nature of work.
Right, it would be nice to do comparative analysis, so once we finish our US analysis, we'll try and get in to do comparative analysis. I think even there, though, what you do see is, you do see this problem of declining labor force participation in other countries as well, so I think it has a lot to do with the nature of work, because even if you do, for any amount of money that you give an employer, the worse the match between a person's skills and the job, the more money you're gonna have to give them, right? So if you're hiring people who have to do a lot of interpersonal interaction, it's gonna take a lot of money before you're gonna hire somebody who's really bad at that. So.
Are you saying, like, there's so much, you covered a lot of ground, headed a little bit soon, but in this last point, it sounded like, the canary in the coal mine, obviously, this notion that people who have, say, mental illnesses and have more work limitations.
Right.
But it sounded like you were also saying that, this is, goes way beyond mental illness.
Yeah, no, so we have seen this phenomenon. We're worrying about the phenomenon of people being closed out of the labor market, or they're not finding jobs. And, the question is, so it's not even a question. My conjecture from that picture, which is not, I don't want to make a causal line, that's just 2 lines, but my conjecture is, people with mental illness are the first ones. When something goes wrong in the labor market, the first people you get rid of are the ones who are the most difficult for you to work with, right? Or the first people who have, if there's a spectrum of people who have more and less difficulty dealing with non-routine cognitive tasks, the people with diagnosable mental health conditions are at one end of it, and there are a lot of people along that spectrum. So what we may be seeing in the decline in the increase in disability is that this mismatch exists. And we could expect that the mismatch is going to go beyond people with diagnosable disabilities, because after all, everything is a continuum. We draw a line somewhere. And this is a broader problem that we're going to face.
So there's been a lot of interesting work with autism and work accommodations, right? And essentially what they've tried to do is show how making those accommodations is added value to productive efficiency, which has made some companies really want to bring in people with typically high functioning autism. But that's an example of, I think, what you're talking about, where you find a better.
If you can find something that is a great match,
right,
then you've got. So we can think about that too. What is a good match? What is a good job market match for a person with this kind of a problem? I think that's harder for many of the mental disorders.
Well, and I've been on a National Academy of sciences, whatever, engineering medicine committee, or task force to look at measurement issues.
Mhm.
And, you know, this is all in progress now, and so I'm not at liberty to say all that much about it. But the measurement issues here are disaster. In other words, we have very few good tools to measure any of these things in an efficient way, you know, whether it's the different intellectual skills that are needed, you know, for different jobs. And, you know, so I just don't, I mean, this is like a situation, and the Social Security is
Right,
working on this,
this,
they're
right.
trying to
Right.
address this problem. But, you know, I see, you know, the tools are extremely limited because the work, you know, assessing workplace needs and demands is very complex.
Right. So there are categorizations of jobs that talk about on different dimensions which we're going to use. I haven't looked at them yet, but we are going to study, which might help. But then I think we also have to go back and think about our patients and think about what the people that we're talking with and how do we assess where they fit in. And we don't do that.
There's very few tools in mental health that even include work functioning.
Right, I understand.
We're good at systems, but there's almost nothing.
Right.
That, except in maybe in the depression world, and in the depression world, those have all been sort of developed with people who are working.
Right,
You know,
right.
and people
And
are
those are actually very idiosyncratic, like how many calls you answer,
But isn't this sort of addressed in sort of the ITS model of supported employment now, right? That you put, because I think the implication of what you're saying is that people who have mental illness are going to be relegated to a particular type of work that is going to be the low end of the curve as the curve is switching towards a different type of profession.
and there will be fewer and fewer of those jobs
And
available.
there'll be fewer and fewer of them available because there'll be more competition at the lower
Right.
end of those
Right.
positions. That's assuming that's, and from the client's perspective, that they would even want to do those jobs. right?
Absolutely.
Whereas sort of the ITS model, that, you know, individual placement and support
Right.
model of support employment, says, give the person a choice about what they think they can do and what they
Mhm.
want to do. Get them that job, and then give them the support they need to maintain.
Right, so, I mean, I think this story says you need to be doing things like that, and I guess the challenge is how are we gonna do them at a reasonable scale, right? And I think the IPS models have mostly been, so I will say, interestingly, that when you look at the SSDI data and you try and see why are people on SSDI, especially SSDI, a lot of that is mood disorders. In fact, that's the primary diagnosis, mainly because people who have schizophrenia never qualify for SSDI. They don't have 40 quarters of work. So I think we've actually thought about it a lot less on the depression front.
So you just referred really briefly to other types of disability, and you showed the slide with people with
Yeah.
limitations, but I wasn't quite positive about your message.
Yeah, so because I had thought, when I put that slide up the first time, I thought, isn't this interesting? Would we really need to see, and I don't know whether I can, I have to look and see, whether people who have mobility limitations, whether the disability rate among people with mobility limitations is falling. You would hope that
You would hope so, because, I mean, this comparison makes a huge difference when you're talking about people with mental disorders.
Right.
Because if it hasn't, if there has been.
right, that would, so we're gonna look, I wanna
All
look
the
at that.
disability rights movement has been for nothing in terms of participation outcomes.
Well, the participation outcomes on average for people with disabilities are pretty awful and have not improved. So the question for me is actually, if you look through disability by disability, are we doing better in the ones where we've seen technological improvements that make it easier
You
to
would hope, but.
Yeah, but it's very hard to, like, there's, lousy data. I think part of the reason we have lousy data, maybe this is an optimistic answer, maybe part of the reason we have lousy data is that people who have disabilities that are, a person who has lost a leg and has a prosthetic leg and can do everything, may not even report themselves as being disabled.
What do you think?
Right, and then I won't find them.
They won't be on.
No, and I won't find them at all, because they won't describe themselves in those terms, and then then they won't show up.
That could be true for a mental health condition too.
Right, right. I mean, I won't even, the people who are high functioning and don't see themselves as having a problem anymore, don't have a problem anymore.
Which raises what do you think, how is this influenced, or these rates influenced by the association or the connection of disability with health insurance?
So it's not much to do with health insurance. What it does have to do with is employment opportunities and wages, but that's sort of, I mean, in my conception, it's sort of circular, right? People can't find jobs that they want to do, and they go on disability insurance. Can't find jobs that pay enough, can't find jobs that are things they'd like to be doing, they're able to do.
But in the long term, doesn't that have a significant impact if pre-existing conditions? So if you're in a state where you can't get insurance.
Yeah, no, so there is an insurance effect, but the insurance effect is not that big. Because a lot of these people are insured, or they're on Medicaid.
The most frequent complaint from the people with mental illness is not so much that they don't have the skill set to do the job, because, I mean,
But they have, right?
but that the jobs are so inflexible, given the somewhat physical nature of their
Right.
condition. And so, I guess it's sort of, in your model, you sort of alluded to inner and outer influence.
Right.
And it really is both,
Right, so I mean, but that goes back to this question of like, are there mainstream policies, like paid sick leave, for example, that make it easier for people with mental illnesses
right?
to remain in the labor market because they can take a few days off work? Family and medical leave, did that help? This is a question I haven't actually seen addressed. But, so just now to put the pessimistic view, I've been really pessimistic today. Usually I'm very optimistic. So on the pessimistic view here, another problem is that a lot of these, the more complicated jobs are, the more training and continuity matter for them, with the exception of physicians. Physicians and medical professionals are the only job where you can go in and out of the labor market with very low penalty. But most jobs, if you go in and out of the labor market, you face a pretty big earnings and wage penalty,
And that's a huge concern for me.
which is a big problem.
But I'm just trying to think of the mainstream, and being the parent of 20-something-year-olds and that cohort of young people who are now moving into the workforce.
Yeah.
Their views about what a good job is very different than sort of, I think, the cultural norms before, in terms of how much time people are willing to dedicate to working. And this idea that, family leave, time off for other endeavors, academic opportunities, you name it, they are pushing for these things. So when they're applying for high-end jobs, they're making sure that their contract allows them this sort of flexibility, or even taking the concept from the medical field or the industrial jobs of shift work,
Yeah.
and working for a certain number of hours over a particular period of time, but it can change and fluctuate. I'm wondering what your thoughts are about that.
So one worry there is that we are seeing, unless we do something about it, increasing inequity in the conditions of work in that respect. So at the same time as you're seeing sort of millennials who want to do book clubs at the office, you're also seeing the forces of, people who, McDonald's you get 3 hours today and 4 hours in the middle of the night tomorrow, and by the way, we're not hiring you on Wednesday. So at the low end, that flexibility just doesn't really exist. Whether we'll be able to build it in through policy, for example, I think is a question.
But I guess that's what I'm saying, that
Yeah.
on a policy level, because if it's not just a small group of young people who are sort of feeling this way, but there's sort of a larger cohort.
Whether we can push in a policy, but I think there too, can we think, so as we think about this, so I asked the state of the science people the question, we've now seen this movement to increase minimum wages.
Right.
Okay, so I think it's a great idea to increase minimum wages, but I'm not sure it's a good idea for people with mental illness that we're increasing minimum wages. They may be the ones who are just knocked out of the labor market because of that. I just don't know, right?
Right.
I'm not saying that it's a bad idea, but I think it's a concern. So I think we sort of need to, what we should do, if I think about the connection between the mainstream and exceptional, it's like my pre-existing conditions picture. We have to, as mental health policy people, we worry a lot about the stuff that comes with a big red banner that says mental health on the top of it. And we don't pay that much attention to all the rest of the stuff. But actually, all the rest of the stuff moves, it's the dog, and the mental health stuff is the tail. And I think a lot of our focus should be on, there are things happening, like they're changing the minimum wage, and computers and other things are coming along and taking away jobs. And what does that mean for the people that we're worried about? Because the people who are worried about minimum wage are not thinking about what does it mean for people with disabilities, or first episode, whatever. They're not, nobody in that world is thinking about these problems, and we shouldn't be only thinking about the things that are just in our.
Neither do we know exactly what people are capable of or what.
No, but right, and so I'm not saying that I know the answer to it. I'm agnostic, I don't know the answer. But I do feel like, what I will tell you is that if I were gonna go back 20 years from now and write Better Than Well again, right? I am 100% sure that the biggest things that will affect the well-being of people in mental illness, unless we come up with some fantastic treatments, pills, basically, is gonna be things that happen in the outside world, not in the mental health world. And so, how do we balance our attention?
That's, thank you, Lee. We're out of time, and that's it's very, we should all be thinking and observing.
Thinking, that's the
Yes. Thank you so much.
We're totally depressed, yes. I know, I'm on your K, and actually you physically, but I know you are. You're welcome. Good. Hey, good. You're very welcome. Hi. Nice to meet you. Oh, wow. Back in the day. Oh, very good. Very nice.
But I like this idea of really looking at the mainstream side of it. We can each